syndrome, status post permanent pacemaker who presents with progressive shortness of breath. Our expert clinician today is Dr. Ian Ross. And for those of you in this audience, there will be an image that will rely on you having gone to conference yesterday and learned from Dr. Sandeep Sodhi about cardiac implantable devices. So we'll maybe throw it out to you to tell us why this device, you can tell what type it is. So I'll introduce very briefly, and then in his own words, Dr. Ian Ross. There are a lot of these great smiling faces on the website. We're lucky to have Dr. Ross here as the Assistant Professor of Medicine and the Medical Education Section Chief at John Cochran VA. He's the co-director of the Medicine ACR rotation. He went to medical school at East Tennessee State University, Quillen College of Medicine, and then went to residency here. It's been a pleasure working with him over at the VA for the last 6 months. He made it wonderful and a great experience there. A constant advocate for patients, a constant advocate for trainees at all levels, and just a great friend as well. So let's give a round of applause for Ian Ross as he steps up.
Short and fairly vague. I am comforted that it's a person that's in my usual patient care wheelhouse, taking care of veterans. I'm at least a little bit comfortable with the demographics I'm working with here. There's a lot of cards and EP in this. So I'll hone in first on the most medicine part of it, which is shortness of breath. Definitely our bread and butter in internal medicine and especially hospital medicine. My approach to dyspnea is a lot like I would imagine a lot of people's approach here to dyspnea. You're thinking about everything that can result in impaired oxygen delivery to the body. Of course, the classic thing is to think about respiratory system disease. Definitely something at the alveolar interstitial interspace causing hypoxemia, but also anything in the entire mechanism of breathing, right? So not just that, but the cortex, the brainstem, the machinery involved in breathing. So, muscles, hemidiaphragms, anything like that can lead to dyspnea. But I would say equally as common, if not more, especially where I practice, is cardiac disease. Whether it's symptoms from congestion, so elevated wedge pressure, left atrial pressure resulting in pulmonary edema, or impaired stroke volume, a lot of these things can cause shortness of breath as well. So I think about it as, is it a pump problem? Which sounds very simple, but then you're thinking about valves, you're thinking about myocardium, you're thinking about everything that can go wrong with an organ as complex as the heart, and also pericardial issues, which often get overlooked and can be difficult diagnoses to make, especially if you're working with something suitably vague and difficult to diagnose like constrictive pericarditis. And then also the conduction system, right, which is a lot to do with the one-liner that we're dealing with here. Of course, anemia, that will impair oxygen delivery, resulting in shortness of breath. In my patient population, I think a lot about slow blood loss that maybe is not as evident in patients. Definitely nutritional deficiencies, iron, folic acid, B12 for sure, but also copper deficiency, which presents a little interestingly, or zinc excess, which can also result in the same kind of picture. And then a CPC favorite, hemolytic anemia, right? So there could be a hemolytic process going on for whatever reason. And then I think about all the stuff that doesn't really fit in those three categories. I think that's fairly low yield. I don't think Carl's going to give me a case of deconditioning or obesity hypoventilation syndrome, but sure, it's on the differential here.
We did do type 2 diabetes last week. So
okay, I missed that one. And of course, you're going to use all of your typical tools here. I do have an integrated POCUS approach, so I very quickly will throw a probe on a patient that has shortness of breath, mainly because I just don't trust chest x-rays. No offense to our radiology colleagues, but they just underestimate the degree of pulmonary edema almost every time, unless it's just florid and there's alveolar filling. So I'm very quick to ultrasound them. And then even though we think about simple questions with cardiac POCUS, it's a great way to screen in for issues and letting me know when I need to get my cardiology colleagues to see the patient early. I wish there was a POCUS finding for anemia. I can't think of one immediately, so I can't really use it for that purpose. Some other things I'm thinking about that I hope Carl will give me in the story, because I think the story's probably going to give me a lot of information here. What is the time course? If it's sudden onset dyspnea, I think about vascular or anatomic courses of pathology. Things that are very serious with vascular occlusion or dissection typically present very acutely. Things like PE, MI, dissection. And things that are anatomic typically present very quickly as well, like obstruction, versus something that's intermittent. Are they having something that they're being exposed to, or are there a little emboli being sent intermittently? That can be more of an intermittent time course versus what's more common, which is like a subacute progressive picture. Exacerbating relieving can be particularly helpful sometimes. Cardiac issues tend to be more positional and nocturnal, not always, but often, and that increases the specificity of those historical factors. The review of symptoms is going to help me work through my onc versus rheum versus other etiologies, so that'll be helpful as well. And then exposures I think about a lot as well, not just with something exacerbating these issues, but have they been exposed to things over their lifetime that would increase risks of certain diseases, tobacco, any of the various elements that can cause pneumoconioses, and in my patient population, also agents of war, right? So Agent Orange or burn pits, which we're now seeing a lot more of as well, which makes patients at far more risk for malignancies, often progressive, very serious ones. Okay, so now going to the part of the one-liner that I'm less comfortable with, tachy-brady syndrome. I definitely see this in my practice. I'm not often managing it because really the management is often putting in a pacemaker, which this patient has. But I definitely did read a little bit about it. The definition is suitably broad, some form of conduction disease, SA disease, with SA nodal disease with a form of tachyarrhythmia. So is it A-flutter, AFib, SVT, ATAC, could be any of these things. So it seems like a very broad term, could be a lot of issues. It could be something affecting the conduction system itself, triggering it. So surges and the parasympathetic or sympathetic nervous systems, issues with the conduction disease or both. Looking at the differential here, I think what we see most commonly is just regional fibrosis, degeneration of this system. CPC catnip, systemic diseases, so definitely thinking about systemic diseases if you read that list, but also infectious diseases like Lyme disease, Chagas, inflammatory, especially things that can affect the myocardium or pericardium. Probably less likely medications or toxins. I think what would be really fun for me is if this was like a PHIO with something normal causing the conduction disease, but that's probably going too far out on a limb there. And then pacemaker placement, yeah, lastly. I don't know what to say about that. We see them a lot. It's fun to pimp the medical student to say like, hey, what are we looking at here, and have them break down what we're seeing. I am often consulting apps and internet to figure out what type it is. So I missed Dr. Sandeep's lecture, so I might be regretting that. The common complications, lead fracture, thromboemboli, endocarditis, various mechanical issues. That's not really that hard to diagnose, so I doubt it in CPC. What is particularly compelling to me are the uncommon complications. So something going on with the electrical impulses generated by the pacemaker, maybe are not strong enough to capture, or there's something going in the myocardium preventing that impulse from being captured. Again, going back to systemic diseases, is something changing within the myocardium that's causing pacemaker dysfunction. That's just kind of where my mind went, but I think it's very likely you can go to the next slide. This is a red herring. A lot of people have pacemakers. A lot of our patients have pacemakers. So I'm trying not to get too distracted by that in the one-liner. That's all I got.
Well, great. Thank you so much, Dr. Ross. That's a great way to work through how you'd work through the particulars of the one-liner, identify the different problems that are inherent to each. So we'll begin with some HPI, some of which is here, and I'll add a little bit more detail as well. So this 68-year-old gentleman who has tachy-brady syndrome and a permanent pacemaker came to the ED because he was laying flat for an outpatient EGD. So not quite as relevant to the case, but he had in the past a GI bleed and then had a non-bleeding gastric ulcer. So they were planning to do an EGD, and as he laid flat, he was unable to maintain laying flat. He became so short of breath, and this has worsened over the past week. It's worse with exertion. Previously, he had some dyspnea on exertion for about 150 feet. Now it's about 15 feet. It's relieved with rest and staying upright. He has been sleeping in a recliner. He doesn't have any recent triggering event. He doesn't have any chest pain or lightheadedness, syncope, or blurring vision. He has some tingling in his extremities, as well as some edema. They'd been treating him for his edema by giving him some diuretics, and he has also been on metoprolol, as you'll see, for his dysrhythmia. But basically, he's had this progressive. He's had months of shortness of breath, and he'd had an admission. He'd been treated with some diuretics, but now after this EGD, he just cannot even tolerate laying flat. It's been progressive over the last week.
Yeah, this is a familiar story. You know, when someone is in acute decompensated heart failure, they often present to the hospital for symptoms of congestion and then poor forward flow, so poor stroke volume. We're seeing all of that here. Shortness of breath lying flat will worsen the filling pressures of the heart, so that is a classic symptom, very specific. The only other patients really that I see with that symptom is with diaphragm dysfunction, and usually that's very, very quick when they lay down flat, so it's fairly easy to distinguish. And then dyspnea on exertion as well makes me think like he's unable to ramp up his stroke volume, compensating for the exertional symptoms. The tingling in his extremities, that could be a clue for something multi-organ with the neuropathy. Going back to those systemic diseases I referenced, or it could be, you know, a lot of people have neuropathy for diabetes reasons or other reasons. So not sure how much importance to put on that right now.
Yeah. Moving on to some further details, I know I'd already made you at home with a one-liner, but I wanted to put in the first line of the medical history, just some VA classics, which you should just assume as you present. So he has the usual metabolic syndrome, hypertension, hyperlipidemia. He has diabetes, he has OSA, he has BPH, he has osteoarthritis. He has this paroxysmal AFib and bradycardia with this permanent pacemaker. He has some COPD on home O2 at night, and then asthma, but the COPD is likely more predominant. He has some coronary artery disease. He had a cath that was done in the months to year prior that had shown about 30% LAD disease. So that's kind of the significance of his coronary artery disease. He's had both of his knees and both of his hips and a shoulder all replaced. His family history notable for a cardiac disease in his dad and grandfather, and then some lung disease in his mother. He's had ertapenem for a UTI in the past that gave him a rash. His medications here, listing all the main ones. He had also been taking some diuretic that he'd not taken this morning, some bumetanide, but that's his list right there. And then for his social history, he was a dairy farmer and had exposures to the animals and different farm items, but nothing more significant than that. And then he's never smoked, he does not drink alcohol, and he has no other drug use.
When you say retired from dairy farming, is that like a week ago he retired or years ago?
It's been a few years from when he retired from dairy farming. Yeah.
Okay. I mean, that's interesting. You know, certainly farm animals are full of all kinds of interesting exposures from an infectious disease standpoint, things like brucellosis, some of these things that can cause culture negative endocarditis. So that's interesting. The medication's fairly normal, I think, for what we see, with the exception of Xolair, which we don't often see that much at the VA. But yeah, the comorbidities, very comfortable place.
Right. Moving to the review of systems, he has fatigue. He has the shortness of breath as noted, dyspnea on exertion. He's not coughing right now and does not have a wheeze. He has no chest pain or palpitations. He has this chronic epigastric abdominal pain, likely from this ulcer for which he was about to get an EGD. That has been unchanged. He has very few other symptoms in the review of symptoms, no other bruising. He has no wounds or rashes that he describes. And then for neuro, he doesn't have any. He's felt weak generally a little bit, but he also has this peripheral neuropathy, and he's also anxious.
Mm-hmm. You know, the anxious thing is funny because a lot of people get centered on that with shortness of breath. And they're like, I think the patient's short of breath because he's anxious. But actually, I usually see the exact reverse. When patients, especially when they have pulmonary edema or decompensated heart failure, anxiety ramps up really quick. So that to me is not distracting me from the principal thing. It just further reinforces this is probably someone who just can't get enough air exchange.
Yeah, that makes sense. And on physical exam, I'll note that the initial physical exam said that the initial one that was in the chart said that he was comfortable, not in any acute distress, but the medical student note and our Gabe Vasquez-Velez's note, actually. Both said that he appeared very uncomfortable, clearly was not doing well without the supplemental oxygen. He's now up to 6 liters. He's hypertensive, tachycardic, tachypnic, requiring more oxygen than at baseline. They estimated the JVP at 10 centimeters. He has pitting edema bilaterally at his feet. He has crackles to the mid-back bilaterally and some decreased sounds at the bases. He has stasis dermatitis in the bilateral lower extremities. A shout out to the medical student who wrote a great description of the skin findings in the lower extremities. So no rash that is new for him other than the stasis dermatitis. And then he has a fairly intact neuro exam, an appropriate mood and affect, which we might agree is anxiety.
Mm-hmm. Yeah, I think not a lot surprising in the exam here. The hypertension, we definitely see if patients are, not taking their home afterload reduction medications, but also just when they're volume overloaded, especially this systolic worse than diastolic elevation. That often gets better with loop diuretics. The JVP exam warms my heart. I've worked a lot with our students and residents to correct the way this is reported. So seeing it not reported as mid-neck or like above the clavicle, that A-okay, that's great. Yeah, I don't think there's too much else here to go through.
Yeah.
This is a sick patient.
Yeah. To emphasize that, we'll get his initial labs, which point out that his CMP is relatively normal, and this creatinine is essentially at his baseline. His total bilirubin is elevated, and he has an elevated protein, and his lactate was up to 2.3 when he came in initially, and he does have this anemia to 12.7. His MCV is within the normal range, and then his diff is normal.
Yeah, so a little bit of a congestive picture with a hepatopathy. Certainly can see that with acute decompensated heart failure, especially. Could also be something infiltrative though, and especially with the elevated protein gap, I worry about that, especially thinking about some of the systemic diseases that can cause the conduction issues we talked about. Certainly amyloidosis. Could also be that he is mounting an inflammatory response from another process, maybe infectious or inflammatory. So that's something you'd want to work up pretty quick in this picture. The anemia, not that exciting, especially in someone with heart failure. You usually see more profound anemia. We'll see how that changes. And the lactate, I think, just emphasizes this is someone who's pretty sick. So spare no diuretic.
Yeah. Amen. All right. So this might be like a Lasix 40 milligrams daily kind of person. That's what I'm hearing.
This is someone who, what was the creatinine again? Do you remember? Yeah. Yeah, so you could start with Lasix IV 40, but you're probably going to put a Foley catheter or at least some type of reliable urinary measurement, probably because this patient's too sick to go up to the bathroom. And if you're not seeing a diuretic response within an hour or two, you're doing 80, you're doing Bumex, you're doing inotropes, you're doing whatever you need to do to get this patient to urinate. So it's not just follow up the next morning. This is someone who you got to really be aggressive with early.
Right. That makes a lot of sense and an important teaching point. So we'll transition to our diagnostic slide here. So we have a few different selections for you. We have basic imaging, which you might anticipate what that might involve. Some infectious evaluation, some urine studies. We have an anemia workup for your interest in the 12.7. We have some advanced imaging with our radiologist here that will come down the line. We have cardiology studies, some room serologies, a bit of immunology, which relates to other systems here that it's hard to loop together. And then finally, of course, our pathology. So how would you like to begin your workup?
I would start realistically as we would with a cardiac PET and some PET.
All right. All right.
No.
How are we on time? I think we have enough time to delay. Well, it's ordered. They're going to start scheduling.
I'm kidding. I'm kidding. Okay. I will try to simulate this because this person's getting a chest X-ray and an EKG as they're coming through the ED. So we can start there and kind of see what that shows.
Awesome. Right. So we'll go with basic imaging. You guessed it. We have a chest X-ray, and I will put this up for you right here.
Yep. So what immediately your attention is drawn to is just the degree of interstitial infiltrates going on bilaterally. A lot of haziness at the bases as well. So this person probably has bilateral pleural effusions and enlarged cardiac silhouette. Don't see any obvious pericardial calcification, which would be a really nice low-hanging fruit if I could grab that, but unfortunately, no. And then the aforementioned dual chamber pacemaker is obviously visible. I don't see any lead fractures, which is good. Yeah,
Great.
some
So
hardware in that shoulder too.
it is way up there in the shoulder. I was once in a cardiology clinic somewhere, and the patient had his pacemaker placed, and then said, "Hey doc, I'm really into shooting, and I'm left-handed. Do you think I'll ever be able to do my like hunting again?" And I said, "I'll escalate that question," because I was an intern. But important that you get the sidedness right. And then can anyone just point out why this is probably not an ICD by looking at these leads or the device itself? No coil. Yeah. So usually you would have a very thick coil down here that allows the vector to be created right here when you are going to defibrillate a patient. And then sometimes you may see some extra, the IC or an ICD would appear larger, would also have a capacitor that could hold charge that would be able to work for that. So great.
I guess I would say the hyla also look a little full as well. Hard to say whether that would just be, the pulmonary circulation is quite dilated, obviously, in someone with heart failure, but on the differential would be, lymphadenopathy.
Yeah. Perfect. Okay, so we'll go back. And of course, it sounds like, we want to definitely get an EKG. So we'll go straight to the EKG.
Was
so
the official read on the X-ray any different or pretty much the same?
No, I think that's great. And then any changes that you would suggest? No. Perfect. All right, that's what we expect.
Helping my confidence.
So we have an ECG today. This is the ECG when he came into the emergency department, which maybe belies documentation of irregular rate and rhythm. And I also have a historical EKG from before he had his pacemaker, if you want.
So I definitely see some pacing spikes. So there is pacing activity going on with the narrow complex beats as well. So he's not 100% paced from what I can see here. Yeah, let's look at the historical one too.
Yep, and I'll pull up. This is a historical that he had. So this was taken about 4 months previous before the pacemaker was placed.
Yeah, it's hard to really make out P waves here, probably because he's in AFib. But I do have some EP colleagues on my speed dial as well in case they're needed. So I can loop them in here.
We might need them.
But yeah, I don't think there's any slam dunks here that I
don't think so. I think when they read it, they pointed out that what may be this ventricular rhythm may be junctional, and was part of why when he was symptomatic, they placed the pacemaker. Also pointed out that in Dr. Sodi's lecture yesterday, that he was talking through when you would place a pacemaker, and in patients, it becomes very important if they're symptomatic or not, if you have sinus node dysfunction.
I assume he was.
And he was, yeah. So we come back to the main slide. We have, of course, more workup we can do, more cardiac workup that's possible. Where should we go?
I guess the question is, where would I go next? Right now, this looks like acute heart failure. I'm going to ignore the fact that I'm in CPC. So I would throw a probe on the chest. I don't know if that happened here, but I guarantee someone got an echo. So I bet we can look at that too.
That's true. All right. So we'll go, I'll just point out some of the labs that they obtained as he came through the ED. Just consistent with what you've said, we have an elevated NT-proBNP and a very mild high sensitivity troponin elevation. And then moving into our images here. So right here we have our parasternal long axis.
All right. Maybe a pointer. Can I have like a laser pointer?
Yes.
Or I could just come over here and do the. I can also just come over here and work the mouse here. Yeah. It stopped playing though. Thank you. Okay, so parasternal long axis view. You can tell this was not done by a POCUS user because it's not the appropriate depth. You need more depth here because you can't see the descending thoracic aorta. So this is a very limited view where you're really only looking at I lost my pointer. The RVOT, you've got the interventricular septum, you've got the LV free wall as well, the mitral valve with the anterior and posterior leaflets, and the aortic valve. Let's see if I can play this again. Let's take a look at that.
If you want to do the laser, I
Yeah,
can point.
sounds good.
For you.
So, what your eye is drawn to, which actually shows up a lot better on screen than it does here. Certainly the myocardium is thick, very thick, and shows up especially well on a parasternal long axis. That's not necessarily a POCUS finding, but it's just something you can't help but see when you've looked at enough of these. Can I come back over here and see it a little bit better?
There's a contrast view as well.
Yeah, I think what's interesting is the patient's anterior leaflet of the mitral valve is coming very close to the septum. This is a surrogate for systolic function, so it would screen out essentially systolic dysfunction with a high degree of accuracy. So that probably lets us know we're looking at a heart failure with preserved EF type situation. Obviously, the left atrium is very enlarged. You can tell that by comparing the sizes of the RVOT, the ascending thoracic aorta, and the left atrium to see that the left atrium is quite a bit bigger than all of these. The aortic valve looks morphologically normal. It's opening and closing widely. I don't see any ascending thoracic aneurysm here, which you can identify on TTE, although it is a little maybe enlarged. What's interesting, though, is this little circle here. So that is not the descending thoracic aorta. It's far too small for that. And you can see that it's within the pericardium here. That's a dilated coronary sinus. And that's just like the JVP. You would expect to see that quite evident in situations with elevated filling pressure. Not that it really helps you clinically here, but certainly it fits with what I would expect to see. What's wrong with this image? There's not enough depth, which is what I said. And so you can't tell if there's a pericardial effusion back here. You can't tell if there's a pleural effusion. I bet there is. So maybe we'll have some better views coming up.
And just to point out, that's where you put your additional lead for a CRTD or a CRTP, it would go right in there. So just going to the next image here, this is just pointing out that they use some contrast so that you could see the chambers a little bit better that I thought I would include for everyone. Then here we have essentially a short axis view.
So what's interesting? Oh boy, it really shows up poorly here, doesn't it?
Are we able to turn the lights off? Because that might help us a little bit. Sure, someone is near lights or could kind of bump into it.
Well, just going by what I see on screen. So certainly the myocardium is thick. The concern for something infiltrative just keeps going up. So of course, thinking through that differential sarcoid, amyloidosis, hemochromatosis, those are the big ones I'm thinking about. The LV cavity is small as well, which is usually why these patients develop symptoms from stroke volume being impaired, is because the LV cavity is so small. And eventually we'll develop systolic dysfunction too as the infiltrative process gets worse.
So transitioning just to point out a little bit on contrast, just so you all can see this a little bit better. And then here we have kind of an apical four-chamber view.
Yeah, so the degree of septal enlargement continues to be impressive. The lateral wall is not as well seen. And you see that the right atrium is bigger than the left atrium, at least from this view. And again, the E-point septal separation, the degree of this anterior leaflet, you can appreciate it. Although it's not measured here, you can see that it's almost hitting the septum, showing that at least from a systolic function perspective, it's preserved. Probably a left pleural effusion here that we're seeing. It's a little bit hard to make out because of the artifacts there.
And just pointing out for all of you a little bit on contrast, just so you can see all of it. And then we also have an IVC view here.
If it's anything other than plethoric, I would be shocked. And of course, if it's normal, then we're not going to diurese the patient, right? No, that's a complete logical fallacy, right? No matter what the IVC shows, I'm going to diurese this patient. But yeah, in the setting of elevated left atrial pressure translating to the right, you certainly expect to see a plethoric IVC with minimal respiratory variation, which is what we see here, and then the dilated hepatic vein along with that as well.
Great. And then just pointing out, that they essentially concurred. They calculated the ejection fraction at 45 to 50%, so relatively preserved but mildly reduced. And they noted grade 3 diastolic dysfunction. There was some trace regurgitation of the different valves, but the big findings were marked LV hypertrophy, some mildly reduced ejection fraction, and very significant diastolic dysfunction.
Yeah, with grade 3 implying, the degree of severely elevated filling pressures, right? Which tells you essentially what the clinical presentation already told you. This is a HFpEF picture. You're thinking about something infiltrative, you're thinking through maybe the restrictive cardiomyopathies, though I didn't see the ventricles quite as small as I would expect there out of proportion to the atria if you're dealing with an entity like that. So at this point, what's nice is that he already had a cath a few years ago, right? Because, just bread and butter, you would be worried about ischemic costs of this,
right?
Especially given the patient's age, gender. So that is already looking less likely with the clean cath a few years ago. So I would proceed down the infiltrative route, get some basic labs, get iron storage screening, TSAT, ferritin, SPEP, UPEP, free light chains. Yeah.
Great. All right. So I'll just go through briefly. We'll just look briefly. They did a very limited anemic workup, so I'm just going to point this out here. All right.
I will say, though, we can just keep playing this.
We'll go back.
Anyone who's rotated with me at the VA know I take iron deficiency anemia very, very seriously, especially in patients with heart failure, because you see incredible clinical outcomes when you correct that. Not that this patient had a high degree of anemia, but just as a teaching point, you would actually screen for iron deficiency and correct it with IV iron if you were to find it, and this was not CPC.
Right. And unfortunately, it was not done, so I apologize. All right, so looking at urine studies here, just to point out, and our immunology shows more of the SPEP and UPEP that you asked for, just pointing out some of the basic urine studies that were done here in the 24-hour urine collection. I'm not sure that this is illuminating too much for you.
The urine findings are interesting. Why does he have so many whites and reds there? I don't know if he's catheterized and maybe there's just some inflammation going on in blood. I would say that's not expected given what I've heard so far.
Right.
I bet he had a Foley catheter.
I bet he did. So then transitioning on to immunology, pointing out some of what you had asked for. So for the serum protein electrophoresis, it was within normal. They had mentioned a possible abnormal restricted peak, but the serum immunofixation did not notice a paraprotein. And then he did have some elevations of the serum free light chains here.
Mm-hmm. Yep, fairly uniform elevation though, so less likely, a monoclonal process going on with the ratio just being barely out of the realm of normal.
Mm-hmm. And then going back, there was a little bit of room serologies that they took. They also did a TSH that was within normal. And he did have a normal ESR, but his CRP was relatively elevated or pretty highly elevated. And then his ANA was 1 to 160.
Yeah, and this is where your review of systems and your physical exam is really important because certainly rheumatologic diseases can cause cardiomyopathies with a whole host of findings. I didn't see a lot of classic things there, but you would think about scleroderma, you think about RA, lupus, though there's more specific findings on echo you would expect to see. So it wouldn't surprise me if you sent like the SCL70, the centromere, a more robust antibody panel. But yeah, I think it's probably low yield in this patient.
Makes sense. So pointing out a little bit, reviewing a little bit of what we've seen, we see a patient that is a 68-year-old gentleman. He clearly has some multi-system disease, but importantly here, we see evidence of heart failure. We have a mildly reduced ejection fraction, very significant diastolic dysfunction. He has conduction system disease. You've pointed out that you'd be worried about infiltrative disease. We also have this neuropathy. The SPEP and UPEP have turned out to be relatively normal, some abnormalities on the immunofixation, but I'm wondering if that dissuades you at all.
Yeah, it makes AL amyloidosis less likely, right? You don't have a monoclonal process leading to this deposition. Could it be another form of amyloidosis? Certainly. Sarcoid would be high up on the differential still in terms of infiltrative processes that can lead to this. A lot of this is the world of advanced cardiac imaging. So thinking about getting like a cardiac MRI or a cardiac PET, going down that route, even a biopsy, which I think I see a lot more frequently these days than when I was training. Did they do a strain pattern on the transthoracic echo?
It was, I think, -2%, so reduced strain.
And you classically will see like the apical sparing pattern with amyloidosis, which I'm guessing was not seen.
They did not note an apical sparing pattern, but I think one thing to highlight for everyone as we're moving through this case, this patient came in with clear heart failure. They're being treated and diuresed. We have a cath that's normal in the past, so the label non-ischemic cardiomyopathy gets slapped onto the chart. But one thing you will see, and I have committed, is kind of a satisficing approach. We have non-ischemic cardiomyopathy, we're going to diurese them, and then we're going to discharge them from the hospital. But one thing I think we see working out with Dr. Ross here is, no, but what is causing this cardiomyopathy? Because we need to get to the foundation of that. So you'd mentioned some advanced imaging. He couldn't lay flat for a cardiac MRI, but I'd like to welcome Dr. Scott Bugenhagen here, he's an assistant professor of radiology in the cardiothoracic imaging section. And we have a CT chest high resolution, and then this myocardial SPECT. So we'll transition these per slide.
All right, thanks for inviting me today. This is the patient's CT scan. By the way, this was a high resolution CT scan that was done to look for interstitial lung disease. We didn't see any interstitial lung disease, so that's a pertinent negative here. But what we did see is stuff that's kind of concordant with what we've seen on the X-ray imaging and echo, which is there's some septal line thickening kind of along the secondary pulmonary lobules, which is suggestive of a pulmonary edema pattern. There's different types of pulmonary edema. A pertinent positive in this case is that the patient has this small left pleural effusion, and that kind of makes us more think along the lines of a cardiogenic pulmonary edema, which is consistent with the fact that his heart looks enlarged. He's got the pacemaker that we saw in X-ray. It's a non-contrast scan, so it's a little bit hard to evaluate the thickness of the myocardium, but we got a good look on that on the echo. So all kind of consistent with the things that we've been thinking so far. All right, so they got patient could not get an MRR. Luckily, there's another test that we could do. This is a PYP scan. It's a radio labeled pyrophosphate scan that we label with technetium. This is a scintigraphic image. It's kind of a planar imaging technique that we use after giving this tracer, obtained about 2.5 hours after injection. So these planar scans are, they're kind of blurry, but the main takeaway here is we can see areas of uptake, particularly diffusely throughout the heart. And the key to interpreting this exam is to look at the myocardial uptake and to compare to the rib uptake. Actually, by the way, this PYP scan, this was originally developed as a bone scan, but we now use it more just for this kind of workup rather than to look at the bones, because we have other better tracers for the bones, like in technetium labeled MDP. But we still use this PYP scan for this to work up this case, this kind of cardiac thing that we're kind of working up with this case. So that was a planar image I showed you. This is a SPECT image. We combine SPECT and the CT images so that we can better co-localize areas of uptake. So in this case, again, we can see uptake within the myocardium. You can see it really well, particularly on that lower middle image, kind of within that septal wall of the myocardium. And when we compare to the ribs, you can see the ribs nicely on those fused images. It looks like the uptake within the myocardium is higher than within the ribs. And there's kind of a scale we use when interpreting these exams. It's called the Perugini scale. It's a scale that goes from 0 to 3, and that's all just, again, based on comparing myocardial uptake to rib uptake. 0 would be no myocardial uptake. 1 would be less myocardial uptake compared to rib uptake. 2 would be equivalent uptake of myocardium relative to the ribs, and 3 would be higher uptake within the myocardium in comparison to the ribs. So in this case, we interpreted it as a Perugini score of 3.
Great, thank you. Anything that this lights up for you, Dr. Ross?
Obviously, I ordered these tests all the time, so I understood every word of that.
As we all did, I'm sure.
Yeah, I guess I would be scrolling through all of that text and looking at the impression on the bottom. It's like, yeah, interesting.
Yeah,
How do I
yeah.
interpret that?
I think we have some holding back on the full impression here.
Yeah, I can imagine. No, this is the first time I've ever seen this test, so I do not have a lot of thoughts.
That's okay. Did you want to add?
Yeah. So, per Gini scale. So it's a scale. It's something we use. This particular scan is used to work up a cardiac amyloidosis. And the scale that I just told you about is kind of tells us our level of suspicion for whether cardiac amyloidosis is positive or not. So level 3 would mean that we have a high, it's almost diagnostic for cardiac amyloidosis. One thing to know about this type of scan, though, it's a better test for a particular type of amyloidosis. That's the ATTR type amyloidosis rather than the AL amyloidosis. And that's because a lot of times the AL amyloidosis is negative on this scan. So it doesn't help us when we have a negative scan. And for example, if we had positive SPEP and UPEP, that's kind of conflicting things that we're seeing there. But if we have, in this case, we had the negative SPEP, UPEP, and we had very high myocardial uptake. So pretty much diagnostic as far as an imaging standpoint of a ATTR type amyloidosis.
Yeah, I hear you that it's diagnostic, and yet I see a pathologist here as well. So I'm guessing there was a myocardial biopsy done.
So yes, Harith is here, our great pathologist. He's a resident in the anatomic and clinical pathology. And so technically after discharge, this patient underwent an endomyocardial biopsy. So
yeah, so thanks for having me. So this is a representative section of a normal endomyocardium. So starting from left and moving right. So we have our normal endothelial lining, very thin, flattened endothelial cells. Yeah, right there. And then just below that, we have a thin layer of some subendothelial connective tissue. And then all the rest of this is myocardium. And this is relatively normal myocardium. We can appreciate just, how homogeneous the cardiomyocytes are in morphology and character, and we have our nuclei. So just burn this image into your brains. This is what a relatively normal endomyocardium looks like. So this is our patient's endomyocardial biopsy. This is a low power representative section here. So I think we can appreciate there's something going on here. It's not quite as homogeneous as the first one, and we have different shades of pink here. And in pathology, we start to appreciate the many different shades of pink. But here, in particular, we have our normal cardiomyocytes are darker, this darker pink, almost reddish hue. And then you can move on to the next slide. It's a higher power image here of the endomyocardial biopsy. So the black arrows are pointing out the normal cardiomyocytes. But the yellow arrow is pointing out this area that's this amorphous, kind of ill-defined acellular area that's actually expanding the interstitium of the myocardium. So, and it's actually entrapping some of the cardiomyocytes in between there as well. Yeah, some of the cardiomyocytes are in there, sneaking in there. So this is obviously not a particularly good sign. However, this finding on histology is pretty characteristic for, well, now we know what it is now. Yeah.
You do some staining on this as well, like the Congo red?
Yeah, so this is a Congo red. This is our Congo red stain here. And the interstitial expansion, the amorphous area or the acellular area is very congophilic. So staining very prominently pink here, just pretty diagnostic for amyloid.
So just want to point out, we do have all the evidence that we have right here, but any final teaching points or process steps you would have for this patient?
I think just keeping a broad differential, right, and thinking through, I don't know if that had to do at all with the patient's history of having a pacemaker and the tachy-brady, whether there's something infiltrative going on for quite some time.
Right.
But I feel like those are things we see so often and don't even think about it. But if that pacemaker was like a year or two prior to this, and this was a progressive picture, that's what we're paid for, is to think through this and to have an open differential. So not just saying, like you said, non-ischemic cardiomyopathy, I'm done. But just maintaining an open mind.
Yeah, I would say that this patient had been through kind of a slow treatment for non-ischemic cardiomyopathy for upwards of a year by the time that we made this diagnosis. So pointing out, just as you said here, if you wanted to add anything.
Yeah, so amyloidosis. And then I think consistent with his serologies as well, that the kappa and lambda wasn't very really predominant either way.
And then one thing that you had pointed out when I'd asked you about this, about the SPEP and UPEP, is you'd mentioned other types. So I want to give you a moment to say what diagnosis you have for this patient now that you've heard it. But
Yeah, TTR is what I heard. The
Right.
wild type.
yeah, so pointing out this was sent out for mass spectrometry, and then we see this diagnosis.
Yeah, so sent out for molecular, and then mass spectrometry did detect an ATTR, and no clinical findings to suggest like an inherited. This is probably just not, or sorry, a hereditary transthyretin. So this is probably just an age-related ATTR.
Great.
Great.
Let's give a round of applause for all of Dr. Ross's teaching for cardiac ATTR wild type amyloidosis. So just pointing out for you that the patient was decongested. In the outpatient setting, he was treated with tafamidis, which I think this is a really important thing to underline, our ability to diagnose. He probably had a delay in diagnosis for a therapy that could have been helpful, this pharmacological chaperone that stabilizes the correctly folded transthyretin proteins. He was considered for patisiran early access protocol. That is a small interfering RNA drug that interrupts the genes that are producing the abnormal transthyretin. Unfortunately, he passed away on hospice about 2 years ago, less than a year after the diagnosis had been made and a year of multiple admissions for heart failure. So pointing out, I know we're essentially at time, but pointing out some of the images exactly that we already had some teaching on in the grading system, and pointing that out for you, and then highlighting some teaching points that really have already been elucidated, which is great. But I just wanted to point out to you the AL versus ATTR, the transthyretin amyloidosis. So, some might have been dissuaded by seeing the normal SPEP and UPEP, and I just want to really bring back to mind that the SPEP and UPEP usually do not show monoclonal proteins and are not going to be positive in your transthyretin amyloidosis. So you would have premature closure if you didn't continue pursuing it. A concurrent IMGUS may occur in ATTR amyloidosis, which can happen. And then just pointing out the differences in the light chains, obviously in the light chain amyloidosis versus this transthyretin, the TTR protein in ATTR. And then there's the genetic form or age-related, which is termed wild type. The light chain amyloidosis, you'll have more likely a multi-organ involvement. And then transthyretin often points out cardiac and neuropathic disease. So the patient that indeed I was trying to hint towards you in the peripheral neuropathy, despite the diabetes. All right. Well, thank you all for your attention. And let's thank Dr. Ross, co-chiefs, and Scott Harmon. Thank you. I loved your shades of pink there.
Discussion. Great case.
Thank you. Yeah, that was enjoyable.
This was once very rare to see.
What?
Cardiac amyloidosis.
Right?
Until not too long ago.
Yeah, I had this slide set at the end.